Good evening to one and all present here for our international speaker program, wherein we labs refractory FLT3 positive AML. Today we have with us Dr. Rahul Bhargava. He is Principal and Director, Hemato-Oncology and BMT Fortis Memorial Institute, Gurgaon. I would also like to introduce Dr. Paresh Vyas. He is our international speaker for the evening. Sir is a professional fellow in medical sciences, professor of hematology, Weatherall Institute of Molecular Medicine, consultant hematologist, group leader, MRC, Molecular Hematology Unit at St. Anne's College, University of Oxford, UK. Thank you very much for joining us today, sir. I will pass on to Dr. to start the program. Sir, over to you.
Hi, Dr. Paresh. This is Dr. Bhargav. Welcome on this webinar series activities on FLT3. It's a really an enigma these days about FLT3. So just a brief background how the India has moved in past many years is now we have access to 3-day genomics. We tend to get our all 79 gene panel NGS, DNA plus RNA in 3 days. And we have started getting away. We will be asking you this. Is this a right word that can we get away from the PCRs for FLT3 or RFLPs methodologies to pick up FLT3s? Because with this error-corrected thing and the pipeline by the geneticists and the bioinformatics, Dr. Srinidhi has been able to give us the diagnosis in 3 days. Then also we have started doing low-pass WGS at this present moment of time, trying to standardize with cytogenetics to understand whether in one go with with NGS and low-pass WGS, can we get the desired cytogenetic abnormalities so as to give a comprehensive features to the clinician. And not only this, the NGS, MRD, and the DDPCR-based FLT3 MRD, we are testing right now in the country whether the NGS should be the right way to monitor. And it's an exciting data again with the Dr. Srinidhi is available. She's going to speak about that. But with this, I think FLT3 is a problem. And thank God, 2017 to 2019, the ratio went away, and we know all FLT3s are bad. But at the same time, Dr. Srinidhi is trying to write up a paper on kinetics of disappearance of types of FLT3 based on the mutations based on various conditioning regime as well as the regimes which are used for induction therapies. And India is a unique thing. Last time we were talking to Jayestu from MD Anderson. India is unique because we are still using midostaurin quite a lot. But it will be exciting to know in which subsets the gilteritinib or is the time has come to replace entirely midostaurin with gilteritinib if the cost is not so prohibitive. So with this, I welcome you to this exciting event. People across Southeast Asia, people across India has joined in to listen to your great talk so that they can get enlightened about management of relapsed refractory FLT3 in AML. So over to Dr. Prayesh. So Dr. Srinidhi ka talk a bit.
Great.
So Dr. Srinidhi is going to speak about it. Dr. Paresh, before that, the diagnosis and monitoring of FLT3, what is best? I am a die-hard fan of NGS these days. Somehow, this is a transformation for past 6 months. But Dr. Srinidhi and you can actually guide us what is the best way to diagnose FLT3 and then monitor FLT3 and how long to monitor FLT3. Over to Dr. Srinidhi for your presentation first. Dr. Srinidhi, are you there?
Yeah.
Yeah, over to Dr.
Thank
Srinidhi.
you, sir. Thank you, sir, and thank you so much for this. And good evening, Dr. Paresh. And I think it's really an honor to speak in front of you about FLT3, considering the amount of work you've done in the field. So this will be just a very brief introduction, or I would say a more of a snapshot of what we are trying to currently do for the last 7, 8 months at our institute, and very short experience, but I'll share some experience of ours also, that we found some unique mutations as well. And then maybe you can guide us at what is the best part of best possible way we could move ahead, and whether what we are doing is right or not. So I'll just share my screen, and so I hope my screen is visible. Uh,
Yes, it's visible.
right. So my talk is on FLT3 diagnosis and monitoring, and these are my disclaimers. And this is where I work. And the answer to this is wow, that you work in such a magnificent place. But then the other flip side is that the demands of the patients and clinicians in the new AML is that give me more and give it to me fast and give me FLT3. And so we, as molecular pathologists, are under that pressure that we are like guardians of galaxy, that we have to give the FLT3 as soon as possible. So FLT3, we all know, has is one gene and has many faces, and it's a golden molecule. And we know that there are three domains. Just for the audience, I would say there are three domains. One is the extracellular domain, one is the transmembrane domain, one is the juxtamembrane domain, and one is the tyrosine kinase domain, which again has tyrosine kinase domain 1 and 2. And all the mutations which occur in these particular domains are listed here. The ITDs, the famous ITDs, most commonly occur in the juxtamembrane domain, and 30% of them also occur in the TKD1 domain. Why is it important to know? I'll tell you. And PIK3, FLT3 mainly activates the JAK-STAT, the RAS-RAF-MEK pathway, and the PI3K pathway in the downstream once it is constitutively active. So it is very, very important to know where is the mutation occurring and which mutation occurs where. This picture, I think, is very, very important from a very seminal paper which was written in 2021. So these are some of the mutations which occur, and this table is a snapshot of which generation of FLT3 inhibitor would work best in which mutation. And there are some of these mutations which we have also found, and probably Dr. Chitresh and Dr. Rahul are also there in this webinar, and they'll be able to tell you their experience with these mutations when they used gilteritinib or midostaurin. So the active mutations which are identified in AML at diagnosis most commonly are the ITDs, which in our practice we get V592 and Y591 most commonly. And in the TKD1 and 2 domain, the famous D835, the I836. And nowadays we commonly are getting N676 also, which is very surprising because it's not supposed to be very common. And acquired mutations during treatment, that is under the pressure of treatment, we also get a lot of other mutations which can be which show different sensitive to different treatments. So this is how the mutations occur. And this is a golden molecule. And at Fortis, we have found 46 cases of FLT3 mutated AML. I'm sorry for the ITD, but FLT3 mutated AML, there are 46 cases with 17 unique variants. And this is a snapshot of what all mutations we found. And you can see that we found mutations practically everywhere. Although ITD is the most common, but then we found a lot of different types of TKD mutations which are differently sensitive to different TKIs. FLT3 diagnostic workup amid lights and shadows. I'm so sorry. I'm just. So fragment length analysis, is this enough? Basically, this was a 65-year-old man who was referred to our institute with pancytopenia, and the patient underwent 26 cycles of azacitidine, achieving hematologic recovery, and then he progressed to an AML, which showed a FLT3 ITD on the fragment length analysis. However, when we saw that the NGS report showed DNMT3A, IDH1, RUNX1, and U2AF1, but where is the FLT3? So this is a situation which was very commonly encountered, that the FLT3 fragment length analysis is positive and the NGS is negative. And this is what happened basically when we saw the exon 14, 15 of FLT3. So this is for the benefit of clinicians. This is the integrative genomics viewer of the FLT3 gene, where exon 14 and 15 are totally clean. There are no insertions. There is nothing, there is no ITD. It's totally clean. The reads are clean. So what we did next was we did a long read sequencing, and we ran a long read sequencing pipeline using the Oxford Nanopore sequencer. And this is how it is that there are so many ITDs. And so short read sequencing, what we commonly do can be false negative, because the ITD, the length of the ITD, if it is very, very big, it may not get picked up. And that is why the Oxford Nanopore is gaining importance very, very rapidly. So this is how it was different. And probably if we would have just relied on a targeted sequencing or the short read sequencer, we would have given it as FLT3 negative. Should we really adopt NGS then? The answer is yes, because we have better ITD pipelines, we have better tools like Get ITD, Get ITD Seek, and the TKD analysis we don't get on fragment length analysis, because there are several single nucleotide variants and insertions and deletions as described affecting the juxtamembrane domain and the tyrosine kinase domain and the activation loop of TKD2, but also the ED. Many of them cause sensitivity or resistance to FLT3 inhibitors, emphasizing the need for their detection. NGS also identifies the ITD sequence. So there is a difference between typical and atypical sequence of ITD. So basically, what is typical and atypical ITD? I'll just come to you in the next slide. And the NGS analysis could also distinguish ITDs affecting the juxtamembrane domain from the ITDs affecting the TKD1 domain. So basically, what is typical versus atypical ITD? The sequence of typical ITD completely matches the wild type FLT3. That is, if FLT3 wild type was ATGC, then the typical ITD would also be ATGC, repeats of ATGC. But atypical ITD contains nucleotides which are other than the wild type FLT3. That is, they are, if it is ATGC, then it would be ATGC-GC, and then that extra GC. So that is why it is called atypical. And we have seen in real world evidence and some trials that AML patients carrying typical ITDs benefit significantly more from FLT3 inhibitors and induction chemotherapy treatments than the patients with atypical ITDs. So this is also important. That is what NGS gives us and a normal PCR won't, because the sequence will not come in a normal PCR or a fragment length analysis. And then I told you that the NGS analysis could also distinguish between the ITDs which affect the juxtamembranous domain from the ITDs which affect the tyrosine kinase domain 1. And I told you almost 30% cases occur in the TKD1 mutation. And intriguingly, in the Ratify study also, they showed that patients who have only a single mutation in the JMD, or they may 26% have JMD and TKD1, and TKD1 single mutations are 19%. And they show that midostaurin is effective only for patients with a single mutation in the juxtamembrane domain, while those in the tyrosine kinase domain have a worse prognosis. So it's very important to know where the ITD also occurs. All ITDs are not same, neither the lengths are the same. So there are studies which have shown that the length of the ITDs may also affect the prognosis, although there is still a lot of dilemma on that. So it is important, where is the mutation, what is the mutation, and how long is the mutation. So, and how many mutations are also there. So in total, FLT3, I think you need to know everything about it rather than only knowing that it is there. So this is how a typical, the top panel, this is how a FLT3 wild type allele looks like. There will be a single peak. If there's an ITD, that is an insertion kind duplication, there will be another peak, which is the ITD allele. This is the conventional method of doing it. It is very fast. It is good. It is the traditional gold standard. Once when we are in dilemma, we do run this run this also. And Get ITD is a computational tool which is good for monitoring MRD in FLT3 and targeted high coverage NGS. And there are papers which show that pre-transplant FLT3 ITD MRD assessment by a PCR NGS determines post-transplant clinical outcome. And more extensive analysis, more open questions. So this is a case which was an acute promyelocytic leukemia with a defined PML RARA with two ITDs. And you can see we used to report the allelic ratios before, but now we don't. But there are two ITDs, and on monitoring, one ITD was gone and only one ITD was there, whereas the PML RARA was persisting at low levels. So, it is very important to understand whether, how much do you consider as positive, how much do you consider as negative. I'm sure Dr. Paresh will throw light on that to us, and whether these are two different clones which were there. How should we monitor? Is there a role for single cell sequencing? First of all, in this case, is there a role to monitor ITD at all, because it's a PML RARA rearranged leukemia? So expect the unexpected, and 2021 ELN AML consensus told us that NGS Ideally, wherever using targeted agents, we should monitor an NGS-based MRD. However, FLT3 is a little gray zone because there is still a lot of dilemma how much NGS can pick up. Although 0.1% more than equal to 0.1% is considered MRD positive, but we still don't know whether in FLT3 ITD what we actually see as 0.1 is 0.1 or not. So what should we use? The options are NGS plus PCR, only NGS, or don't monitor FLT3 at all. This is a dilemma which is still there because in India we don't really have a lot of tools right now, and we don't have access to the kits which are available, not only because of the cost, but also, I don't know, the adoptability and the adaptability both are still in question because people still prefer to do the conventional fragment length analysis. And even at MRD, they prefer to do fragment length analysis, although that does not offer sensitivity that deep. So this is a this is the kit from InvivoScribe, which at least I'm a very big fan of. And I mean, I'm not endorsing it, but then I think it's a very good tool which does a good NGS-based monitoring for FLT3, both ITD, TKD, as well as NPM1. And they had presented it in AMP, that is the Association of Molecular Pathology Annual Congress, and they depicted a very good concordance between the CDX assay and reference assay, and I think it's a very good tool. It goes to a very good sensitivity, and we should aim to get there, although there is a cost restriction, especially in this part of the country, to do an NGS only for FLT3 alone if there is a plethora of mutations and if there is a lot of genomic instability in a patient happening. So this is, are we ready to say RIP to PCR once we have a 3-day oncogenomics? That is a tool which I have in my lab right now, which is the Genexus, because we are a hospital-based lab and we always want everything to be fast, and also the restraint of availability of, too many qualified scientists and personnel. But then now we are slowly expanding. We are getting some more NGS machines and a digital PCR. So that is what we have right now. We deliver reports in 3 days. We try to do NGS MRD also, and we do error-corrected sequencing. We remove PCR duplicates. We try to reach to a sensitivity of 0.01. We are not able to go below that right now, but we are still in the pursuit of doing the best we can. But we try to report all the types of mutations we get. Even if they are novel, we try to validate them on an orthogonal platform. And we also try to report the drug sensitivities based on the literature and evidence available. And thank you. I'm happy to take any questions, please. And I'm so sorry for the interruptions from my 3-year-old.
Thank you, Dr. Thank you, Dr. Srinidhi. Just briefly to summarize, what is your choice of diagnosing FLT3? Do you think it's still PCR, restricted fragment length analysis, InvivoScribe, or NGS is sufficient enough? Because we are looking for one comprehensive test which gives us all, rather than dividing the sample at every station and increasing the cost.
So, so right now my choice is what right now currently we are doing. We are doing a 3-day genomics, and that NGS is good enough because it has broken the FLT3 juxtamembrane domain into many tiles, which kind of increases the sensitivity to detect the ITD and does not miss. And we have seen that the concordance between the FLT3 of Genexus and FLT3 of any other NGS is very high. And that is why they're using it in the myelomat study as well. So my choice is right now to do this NGS. If not, then couple it with PCR also.
And we'll take a quick reaction from Dr. Paresh Vyas as well. Dr. Paresh, you have heard Dr. Srinidhi, what kind of a technology she's playing with right now in India, because we really need to know, because we have midostaurin, sorafenib, gilteritinib, and quizartinib will soon be there. So we want to see actually the FLT3 kinds of mutations which are resistant to gilteritinib or to midostaurin, so as to help the physicians to know which ones to use. So what is your thoughts on her talk, and then we will invite you to deliver your piece of it.
Yeah, thanks. So thank you to the organizers. Thank you to the previous speaker. Excellent talk. We use NGS. We do not use PCR with restriction fragment length polymorphism. We use NGS both for diagnosis, and we use NGS for MRD monitoring during treatment, pre-transplant, post-transplant, post-consolidation.
Perfect. Perfect. So this is the, I think, right way what right now the country is doing. Any word on in vivo scribe? Because Dr. Srinidhi keeps on talking about in vivo scribe. Do you think it's on pore technology? Do you think those things, even if it being acquired in India, would be worthwhile? Or what will be the difference in sensitivity between the GenXs, where you can give a depth of 20,000 X on a MRD sample versus the in vivo scribe and or on a nanopore technology?
Sure. So we don't use a commercial platform for NGS. We use Roche Bates, and then we have our own protocols. And these have been accredited. They're CLIA accredited, they're UCAS accredited, so forth. And for the phase 3 clinical trials that we do, if a company wants, we will do a certain portion of the samples with the in vivo scribe companion diagnostic for the FDA. But in routine clinical practice, we use our own NGS assays. They're much cheaper than in vivo scribe. And the performance with respect to in vivo scribe is comparable. We've taken the same samples and run them side by side. There's no question in vivo scribe is good. It's very good. It's a good assay, but I think you guys can develop your own assays more cheaply, which are as good.
So, Dr. Srinidhi, you have a next task to develop your own essays so that right now, whatever the cost is can be brought down for the people to use this as an MRD. So without wasting much of our time, I would invite Dr. Paresh Vyas, who is being known in the country and does not need any introduction of his various accolades and the way he has been able to guide the field of hematology sitting there for not only for Europe, but across India. So over to Dr. Paresh. I mean, it will be interesting to listen to you. There are a lot of things which we want to develop. We are developing, and the country is moving in the right direction. But still, the 3 trillion economy versus the 16 trillion economy from America still takes a lot of toll on what we can do and what we desire to do. So over to you, Dr. Paresh.
Thank you. Real pleasure. Let me share screen, if I may. Do you see my screen?
Not yet, sir. It has not come yet. Yes, we can see it now.
Let me see if I can move this away and minimize this so you can see everything. I just need to swap displays. Do you see that now?
Yes, sir. It's perfectly visible.
Great. So huge thanks to Astellas and thank you to everybody. Now these slides have to be compliant with Astellas, so I won't be able to share with you all our latest data and information, but it will come through in the discussion. So these are my disclosures, the outline of the talk. The previous speaker has done a fantastic job of covering a lot of this, but I'll spend more time on the clinical side. So as you know, the FLT3 signaling pathway, beg your pardon, is a transmembrane receptor binding ligand activating cell growth and survival. The levels of FLT3 are higher in AML cells compared to normal blood cells. This is even without the mutation. And what the mutation does is to cause ligand-independent activation of this pathway at a high level. The reason I mentioned the high levels of FLT3 RNA and protein is because there is an ongoing trial of FLT3 inhibitor in FLT3 wild type AML, and Pau Montesinos in Spain has some positive data on that. So this has already been discussed, the domain structure. So we'll be talking principally about the ITD domain next to the juxtamembrane domain. The kinase mutations have been discussed already. There are additional activating mutations. So the burden of FLT3 mutations varies with age. This is data now some time ago showing you that in patients under 65 intensively treated, ITD is 20%, TKD is 5%. And as you age, and this is our data in JCO last year, patients over 60 but still fit for intensive chemotherapy, that drops a little bit to 18%. And then this is again our data in over 65s but now unfit, so median age here 74. You'll see that it now drops to 16% from 20%. So there is a reduction in FLT3, certainly in the West, with age. And I was very interested. It seems to be that there may be geographic variation in FLT3 ITD in India as well. So testing for mutations, we've talked about this at length. We prefer next generation sequencing. I won't go through all this because we've talked about it extensively. But really, you must test at diagnosis. You must test again at relapse, and I'll explain why in a minute. And you can have your in-house mutation testing or commercial kits for ITD and TKD. One point that was raised is long read versus short read sequencing. As you know, with long read sequencing, you can vary the read. With short read sequencing to 300 base pairs. That covers most ITD mutations, not all. You will miss some, but only a minority. We do have nanopore, but we don't use it often. We only use it in the cases that are tricky. This is now the inhibitor story. So this has already been discussed. There are broadly two kinds of inhibitors, type 1 and type 2. Type 1 inhibitors that include midostaurin and gilteritinib bind when the receptor is in an active dimer formation, and the type 2 inhibitors bind in the inactive monomer formation and include sorafenib and quizartinib. You'll see the kinome data here. Midostaurin is quite a dirty drug. Gilteritinib is much cleaner, as is quizartinib. Sorafenib is in between. And you can see that the potency of the drug in terms of inhibiting the FLT3 signaling pathway really varies by 2 logs. Gilteritinib is very specific. Midostaurin is much less potent. And I'm going to now move to the treatment of relapsed refractory AML. So you all know that certainly in the era before FLT3 inhibitors, the outlook for patients with AML in first relapse was really very poor. This is ND Anderson data, and you can see in the FLT3 positive group, the outcome is much worse than in the negative group. Small numbers of patients, but this has been confirmed by many, many institutions and studies. And this just shows you that the second CR survival is much less if you get into CR, and the duration of CR is much less if you're FLT3 positive. So FLT3 positive relapsed is poor. All of this data was before FLT3 inhibitors, but even now, today, when you relapse, having prior FLT3 treatment, your outlook is worse. So this just shows you the EFS and OS data for FLT3 wild type versus FLT3 mutant in relapsed refractory AML. It's a poor prognostic marker. This now just is a really important slide. It's important because it shows you that the FLT3 mutation status can vary from presentation to relapse. Please just focus on this row here. There are many studies that have been summarized at the end. So we're looking at the mutation being present at presentation and relapse, negative, 54% of patients, positive, 27% of patients. But about 10 to 18% of patients, the mutational profile changes between diagnosis and relapse, going from negative to positive or from positive to negative. And this is from multiple studies. It's also our clinical experience. That is why at relapse, we will always test again for FLT3. It'll be part of the NGS panel and you'll get it. So just to summarize the key points, FLT3 is a frequent genetic alteration. It's poor risk at relapse. And the FLT3 mutation status impacts survival, but FLT3 mutation testing must be carried out at relapse. Don't assume it'll always be negative or it'll always be positive. The Admiral trial clearly was the pivotal trial that established the role for gilteritinib. And I know that in India, you're now getting gilteritinib. Well, in the United Kingdom, we've used it in the relapse refractory setting now for some time. We've also used it in the upfront setting in clinical trials. So the Admiral trial was a trial that was published in the New England Journal now back in 2019, and 371 patients with relapse refractory ITD were randomized 2-to-1 between monotherapy gilteritinib and salvage chemotherapy. Most of these patients had high intensity treatment, so salvage with MEC or FLAG-IDA, but some patients, a small minority of patients, received low intensity treatment. And the primary endpoint was OS. So treatment was administered in the salvage arm exactly as you would do for standard of care. And in the gilteritinib arm, you had continuous monotherapy dosing as long as there was no toxicity. Patients were eligible to go to transplant if in CR and to resume gilteritinib therapy post-transplant. In the standard of care arm, salvage arm, some of the patients went to transplant as well, and you'll see that later. So the inclusion criteria are pretty straightforward. You had to be in first relapse. Prior transplant was allowed. So you had to be positive for ITD or TKD mutations, as set out here. You had to have a certain performance status, 2 or less, and all the other usual parameters for inclusion. The important thing is you excluded patients who were refractory or relapsed after more than one line of therapy. So the two arms of the trial were equally balanced. Note the median age is in the 60s, low 60s, and you'll see that most patients had prior lines of therapy that included anthracycline. Some of them had had a FLT3 inhibitor, as you can see here, and about a fifth had had a prior transplant. So this is the primary endpoint data. Really impressive. Gilteritinib monotherapy, 9.3 months, salvage chemotherapy, 5.6, with an impressive hazard ratio of 0.62. The curves split early and they continue apart. You'll also see that the 12-month OS rate was 37% for gilteritinib versus 16% for salvage chemotherapy. I'm not going to go through all the subgroup analysis, but essentially all the features that are on this side of the 0 line favored gilteritinib. All of the features on this side of the line favored salvage. And with the exception of unfavorable cytogenetics, which crossed the line of unity, nothing was on the salvage chemotherapy side. Some of these crossed this line of unity simply because the numbers were small. But regardless of age or sex, regardless of course, the better performance status patients, there were more of them, so that's why it's on this side of the line. But in general, gilteritinib was good across the board. This shows you the modified EFS with long-term follow-up, and here you'll see that the EFS was 2.3 months with gilteritinib, whereas it was only 0.7 for salvage chemotherapy with a very impressive hazard ratio. This was a pre-specified analysis that included investigator-reported events. And you can see that the follow-up really goes on for quite a long time, and there is a plateau. And this plateau really comes from patients who were transplanted, as one might expect. This takes us nicely into the transplant post-therapy setting. So here we have patients who relapsed, got onto either gilteritinib, or who got onto gilteritinib, I should say, and then had either gilteritinib post-transplant in blue or did not resume gilteritinib after the transplant. And again, you can see a difference in the survival probability. It doubles your survival with an impressive hazard ratio. So I would say if you have gilteritinib in relapse, you have a transplant, please continue gilteritinib after your transplant. And this shows the OS survival in those patients treated with gilteritinib was maintained even after censoring for time of transplant. In terms of the CR rates, you can see they're better with gilteritinib than salvage chemotherapy, exactly what you'd expect with that prolonged survival. I'm not going to go into the details here, but suffice it to say the composite CR rate was doubled. In those individuals who were blood component dependent, and here red cell transfusion dependent, who were transfusion dependent at baseline, 34 became transfusion independent with gilteritinib any 56-day period post-baseline. So you will get patients out of your day unit, you will get them out of your transfusion center, and that improves quality of life. In terms of the duration of remission and dose modifications, you'll see once you achieve CR, you're more likely to stay in CR. With gilteritinib, it was not evaluable in the salvage chemotherapy arm, and you can see that it takes about 2 months to get into your composite CR with gilteritinib. You'll also see that in most patients, you were able to either increase the dose from 120 to 200, or in some patients, you had to decrease the dose. In my clinical practice, I would say most patients end up on 80 milligrams of gilteritinib, and that's really to maintain their counts at a very adequate level. And certainly post-transplant, very few patients will tolerate more than 80 milligrams of gilteritinib. In terms of the safety profile, this is treatment emergent adverse events. So you look in the grade 3 or more across gilteritinib to salvage, you'll see they're pretty balanced across the different adverse events. The only exception really is that there is a transaminitis signal, which I've seen too, in gilteritinib, and this responds very well to dose reduction or temporary dose cessation. Very few patients have I had to stop, but I've reduced dose and it's been fine. Or I've modified the azole I've used, or I've modified one of the concomitant medications. Otherwise, across the board, very, very similar. There are some special adverse events that we will talk about in a minute. So the median duration of exposure to treatment, not surprisingly, was higher in the median duration exposure to gilteritinib was 18 weeks, treatment exposure 121 patient years, and it was far less in the chemotherapy group, as one might expect. This is the long-term follow-up analysis, and it's demonstrating continued and sustained benefit up to 3 years. So these are the OS rates, 1 year, 2 year, and 3 year. You do see attrition of patients over time. There's a definite plateau in those patients, particularly you take to transplant. Okay, so let's now focus on transplant, because most of the patients will be younger, I suspect, in India. So you have gilteritinib, you receive gilteritinib. How many are going to transplant? 64. Compared to the salvage chemotherapy group, only 19 went forward to transplant. And of those who received gilteritinib post-transplant, 16 were alive more than 2 years. So a lot of attrition along the way, but you're much more likely to have a curative outcome with pre- and post-transplant gilteritinib than those individuals who did not have gilteritinib throughout. Post-transplant gilteritinib is important. You can see only 2 patients alive more than 2 years. So the transplant by itself doesn't do enough. That's certainly been our experience too. Okay, so let's just go on to the clinical outcomes in patients with relapsed refractory acute myeloid leukemia who were treated with gilteritinib, but who had received prior midostaurin or sorafenib. Now, this will be a common situation. It's increasingly common. We use quite a lot of midostaurin in the United Kingdom, but we're switching to quizartinib because that is now in label and funded in the United Kingdom. We only tend to use gilteritinib in the frontline setting in clinical trials because it's not licensed in the United Kingdom in the frontline setting. So this is patients who were treated in both the Chrysalis and Admiral trials who were treated with gilteritinib in the Chrysalis trial, or in the Admiral trial were treated with gilteritinib or salvage chemotherapy. And you can see prior TKIs in the darker box here and here. You can see 33 patients in the Chrysalis trial, 31 in the Admiral trial who had prior TKI. No prior TKI, many more patients, 112 here, 216. And similarly, in the salvage chemotherapy arm, 14 and 110. Now, it's a balanced set of cohorts. And let's look at what happens. So this is gilteritinib being given to patients in the Chrysalis trial. So you'll remember that this is, sorry, I beg your pardon, this is 33 patients versus 112 patients here, as set out here at the bottom of the Kaplan-Meier curve. And you can see if you receive gilteritinib 120 or 200, you're in the blue line. If you had prior TKI, and this is without prior TKI. So prior TKI really does have an impact, but you still get a survival of a median survival of 7.2 months. This is, of course, better than salvage chemotherapy, which was less. And this is the Admiral trial. It gives you very similar results. And here we now see the salvage chemotherapy data as well. So compare gilteritinib 120 prior TKI versus salvage chemotherapy prior TKI. Green versus blue, you can see the clear difference. Without prior TKI, red versus brown. So prior TKI does have a negative impact on the outcome, but it's still better than salvage chemotherapy. And the median OS is set out here, 6.5 to 4.7, 9.6 to 6. Okay, how long should you stay on gilteritinib before you say, monotherapy this is, before you say it's not going to work? And this is important. And this was a post hoc analysis of the Admiral and Commodore trials to really try and understand that. Here we're now looking, how long does it take to reach composite CR of CR, CRH? Here you've got a partial hematological recovery, so your neutrophil count will be greater than 0.5 and your platelet count greater than 50, but not greater than 100 and greater than 1, as in a proper CR. And this is CR with an incomplete count recovery, so you either recover your neutrophils or you recover your platelets. And here you can see, this is the graph I really want you to focus on. So pooled analysis of 205 CRC responders, and you can see it does take time to get to best response. So this is the number of patients achieving CRC on gilteritinib monotherapy. And you can see cycle 2, cycle 4, cycle 6, the number of patients achieving CRC decreases with time, but the cumulative number of patients increases. We typically would say that you should stay on for 6 cycles before you decide not to do anything. Of course, that's also dependent on how the patient is doing. It's dependent on the family's wishes. But we have seen improvement of response over time. And really, that's sort of set out here. Most patients will achieve CRC within 6 cycles of gilteritinib monotherapy. Late responders were more likely than early responders to achieve full count recovery. And late responders more frequently went to HSCT than early responders. That's a paradoxical result, and it's not one I can easily explain. Fewer late responders experienced treatment discontinuation due to disease relapse. So in general, don't give up on gilteritinib until 6 cycles. I just want to say a few things about special warnings. This is PRES, pancreatitis, prolonged QT, and contraception. So differentiation syndrome, I've definitely seen it. It's in about 3% of patients, 2 to 3% of patients, 2% greater than grade 3. That's about right. Just manage it as you would any other differentiation syndrome, for example, that you might see with APL. You'll also begin to see it with the menin inhibitors when they come to India, if they've not already come to India. stop drug, manage the patients with supportive care, give corticosteroids, dexamethasone, typically, if you feel that is helpful. Most of the time, we do use dexamethasone as well. The diagnosis of differentiation syndrome is pretty standard. It's weight gain, fluid retention, fever, dyspnea, pleural and pericardial effusions, and occasionally you'll get a rash, occasionally you'll get renal dysfunction. The management I've already gone through. And then the other thing I've seen only once is PRES, posterior reversible encephalopathy syndrome. As you know, this is a clinical disorder, reversible, usually characterized by headache, seizures, confusion, very rarely other neurological signs and symptoms, often with altered mental state. The MRI imaging is pretty classic, and discontinuation is recommended. In fact, you really must discontinue gilteritinib. It does reverse, and you can't put people back on gilteritinib. Pancreatitis is something that can happen. Again, I've seen it once or twice in folks who have signs and symptoms. It's reversible. Just stop the gilteritinib, and of course, look for all the other causes of pancreatitis. Contraception, very important in females of reproductive potential and males with female partners of reproductive potential. I'm not going to go through this in detail, but it does, gilteritinib is metabolized by CYP3A, so think about the drug-drug interactions. Think about your azoles in particular. Think about your macrolides if you're using those. And there are, of course, all the other usual drugs that CYP3A inhibitors and inducers that you need to think about. So I just want to summarize by saying monotherapy gilteritinib has proved important treatment. It's a widely used treatment in the United Kingdom. We've moved now to using combinations of gilteritinib, and we can talk about that in the discussion. But gilteritinib is really an important drug in relapsed refractory FLT3 mutant AML. It allows more patients to go to transplant, and in those patients who go to transplant, please use it after transplant. I want to stop there and just thank you for your attention.
Thank you very much, Dr. Vyas, for the wonderful presentation. So we do have a few questions in the Q&A. Do you want to take it right away?
I'll leave that up to the organizers, how they would like to do it. So maybe Dr. Rahul would want to comment. Shall I take the questions now, or do you want to open this up for discussion? I'll take the questions now. So
Okay.
the first question is, would it be best to go for PCR and NGS so we don't miss out any FLT3 mutations that may be missed in any one of these? The short answer is we've not missed mutations. We did do both for probably 2 years just to check that we weren't missing anything, but we did not miss, so we now rarely do it. That's not true for every hospital in the United Kingdom. In some hospitals, the PCR and the gel, the restriction fragment length polymorphism is quicker. They can get it in 24 hours, so they'd prefer to do that. But it really depends on what your local infrastructure finds best. But you don't need to do the two if you can do NGS in our experience. I don't know if others would like to comment on that. Okay. The second question is, are there any FLT3 variants that may be resistant to specific inhibitors? The answer is yes. There is variation in the sensitivity, certainly in the preclinical setting, i.e. in a laboratory, between different variants and the different inhibitors, but it isn't as marked as it is, for example, in BCR-ABL and the different BCR-ABL inhibitors. Of course, the type 1 inhibitors do not work with the tyrosine kinase mutations. So quizartinib, for example, you would not use with TKD. That's an absolute. So any type 1 inhibitor, you really need to use only with the ITD mutations. Gilteritinib, for example, is a type 2 you can use with ITD and the TKD mutations. Sorry, is there a question?
Dr. Paresh, does it make sense then, because we have an access to midostaurin and gilteritinib, how do you, I mean, it's a theoretical question. How do you make a choice between midostaurin and gilteritinib then? Because,
Sure.
and if the kinetics say, is it a difference in kinetics of clearance of FLT3 between midostaurin and gilteritinib? Means you give it for 2 months, because Indian population always requires a definitive kind of a therapy that you give for 1 or 2 months, because it's going to cost a lot of money to them. And that's what I tell to Estella, is that if you can, through the international speaker programs, if you can enlighten us that what is the kinetics by that which time you'll be able to clear FLT3 to 0 before the transplant, it will make life easier for all of us.
Sure, got it. So are we talking about in the frontline setting or the relapse refractory setting?
Both frontline and relapse refractory setting.
So as you know, the frontline setting, most of the data is for midostaurin, or it's for quizartinib, which is coming to India. The data in the frontline setting for gilteritinib is far sparser. There is a head-to-head trial between midostaurin and gilteritinib that has been completed, international randomized phase 3 trial. That trial will report later in 2026. But our clinical experience for gilteritinib frontline compared to midostaurin frontline is that if you give adequate chemotherapy, so you're giving a proper induction with proper consolidation, and you're able to get the FLT3 inhibitor on time, the difference between gilteritinib and midostaurin is small. It is a bit faster with gilteritinib, I will agree with that, but gilteritinib is also a bit more myelosuppressive, and we find we can't go above 80 in the post-chemo setting, so for fit young patients. The other group of patients who sometimes start off as unfit but get fitter and go to transplant are those who are in between, say, 65 or 60s and 70, say. And some of them we would start off with veneza, gilteritinib. And here, gilteritinib is certainly better than midostaurin. We don't use midostaurin. There's very little, I know of no experience of midostaurin here. The third thing I would say is that midostaurin, just from a tolerability point of view, certainly in the patients I look after, gilteritinib is more tolerable, whether it's in the fit or unfit setting. Midostaurin has a few more side effects, particularly GI side effects. Gilteritinib's main side effect is myelosuppression, and of course you can just titrate the dose on that. Is that helpful?
Yeah. So, and any idea? So, in a frontline setting before a transplant, there was some JCO article talking about if you're FLT3 pre-transplant negative, then there is no role of giving a gilteritinib maintenance. So, what's your thoughts onto that?
Yeah, that's great. So Mark Levis published the Morphose study in JCO, and his view from that population-based data set is exactly that if you're pre-transplant MRD negative, then you can go into transplant, and the role of gilteritinib post-transplant not so clear. There are two comments to make. The first comment to make is you have to have very sensitive MRD monitoring. You must have that, because if you recall that Morpho paper, they went down to 10 to the minus 6 for MRD. So that was the in vivo scribe kit, and you need to have that degree of sensitivity, whether you're using in vivo scribe or your homemade or local assays. My own view, this is my practice now, is that if you are a young patient and you're going into transplant and your you want to be cured first time round. You don't want to come back and do second CR and all this kind of stuff. If you're not going to use gilteritinib post-transplant, then you have to have very active, continual MRD monitoring post-transplant. Okay, MRD monitoring gives you that safety net. Okay.
Okay.
If you're not going to do MRD monitoring post-transplant, give gilteritinib.
Okay, so if I have to ask you a very provocative question, that is the time limited for flow MRD in AML, because soon the NGS MRD is going to overtake them? What's your thought? Because
Yeah, great question. Great question. Just, I want to finish one comment. How long to monitor MRD in the post-transplant setting, or if you don't take them to transplant chemo setting? Minimum 1 year. Ideally 2. And ITD is explosive. So please, 3 monthly bone marrows.
Yeah.
Now, for an Indian patient, that may be tough. And you say to them, do you want 3 monthly bone marrows with your ITD cost of monitoring, or do you want to pay the cost of gilteritinib? Decide.
Yeah, I think they will lean more towards the MRD, because gilteritinib is still 5 lakh rupees, 500,000 Indian rupees.
I know. But if you're a young person, you really don't want to be in first relapse.
Oh, yeah. Yeah. So I think with these active agents, the FLT3 is not so ominous these days. Dr. Paresh, what
I
is
agree. I agree. It's not. It's become a much more curable disease.
Yeah. So
Yeah.
us, still the major problem is 821 and say NRAS and KRAS. NRAS is like emerging in our data set with Dr. Srinidhi as a new TP53. I mean, we are just not able to clear that. I don't know what to do with that, but that's a question for some other day. Yeah, please.
So there are the following categories: P53, RAS mutations. In my practice, WT1 mutations, not good. I don't know if you see them in India.
Oh, yeah,
And
yeah.
then,
We see from Middle East that the WT1, but we see more of NRAS in Indian setting. NRAS, quite a lot of inflammatory marker setting. I would say marker for inflammation, I would suppose, because once we unravel this inflammation thing, then probably NRAS seems to
I
be
agree
there.
with that. I agree with that. And then, of course, in the older patients, there are all these secondary ML mutations, right? All the chromatin, all that splicing mutations, all that kind of stuff. They're not good either. Now, you asked the question, flow MRD.
Yeah.
So today, we still use flow MRD in our laboratory. And we use flow MRD because not everyone has a proven bona fide marker. But you're right, NGS MRD is going to win at the end. The key is to be able to make sure that your NGS MRD assays are well validated. So you show in your clinical practice with your hospital that they're absolutely reproducible, because the limit of detection has to be set accurately. You've got a great lab, so I'm sure you will do it. But I think at the end, the days of flow MRD are going to go.
Perfect. So with this, thank you, Dr. Paresh, and I'll call my
Can I ask one last question?
Yeah, please, Dr. Srinidhi, please go ahead.
Sir, I wanted to know, what is your limit of detection when it comes to DNA and when it comes to RNA?
Yeah, it depends on the assay, really. So the NPM1 is a highly expressed gene. So the cDNA is very sensitive, and you can go down to easily 1 in 10 to the minus 6. Peter Volk, who works at HOVON in Rotterdam, is a very close colleague of ours. In fact, we've established a central lab in Oxford that works with HOVON, that works with MLSG for our clinical trials now. He published a paper in Blood Advances showing that the DNA for NPM1 mirrors the cDNA. It's not as sensitive, but it is as equally prognostic. So in the trials for the menin inhibitors that we're starting in April, we will compare the RNA and DNA for NPM1. For most other genetic mutations, we use DNA, we do not use RNA.
Right. So I also agree with that.
The only exceptions, of course, are the fusion transcripts, right? So where you have a translocation, we don't use DNA, we use RNA, and then we'll amplify the breakpoint in the cDNA.
Yes. So that's what we also do. And in fact, even NPM1, we also do it on cDNA because I understand that the sensitivity is much, much, much higher than DNA. And that's what we are also trying to do. And for fusions, right now, we are relying more on real-time PCR rather than a lot of NGS, especially for the core binding, but because it requires more frequent monitoring. But slowly, we are trying to shift to NGS. We do send real-time PCR and an NGS, the same sample because we want to establish that concordance as well. So we are trying to do that, but I'm hoping that we'll get there soon.
Sure, you will. I'm sure you will. I was very surprised with the 821s. Two things: the poor prognosis in India. Two things. Firstly, you don't have availability of Mylotarg, and then the second thing was, how often do you see the KIT mutations with 821?
So Dr. Srinidhi has done a comparison of 216 CBF with a TCS database. Dr. Srinidhi, that has gone to ASCO for a presentation. So Dr. Srinidhi can enlighten us about the c-KIT and the NRAS. Dr. Srinidhi?
So we see almost 35% patients with an NRAS, and we almost have like more than 70% patients who at least have one or two co-mutations with the fusion. So we normally don't have a clean core binding factor. And KIT mutations also we are seeing almost in 17 to 18%.
Yeah, that's the problem. So we've sometimes used dasatinib, which is a reasonable KIT inhibitor.
Yes. But then we are
So-
also seeing very weird KIT mutations, not only the D816, we also see the N822, and we also see those in-frame deletions of KIT, which actually people say are inconsequential, but then I don't really know that how much inconsequential.
I don't think they are inconsequential.
Quick question, Dr. and Dr. Srinidhi, both.
Okay, so we have got Dr. Farhan Naheem, who's a consultant and a dear friend at Max Super Speciality Hospital. He has got a case presentation. Over to Farhan. We are just running short of time. Farhan, we need to be slightly more quick so that we can bring our panelists and get benefit of Dr. Paresh's intellectual ability to steer us through FLT3. Farhan.
Thank you, sir. And thank you, Team Estella, for this opportunity. So I was actually asking a question, but I think we are running short. We can discuss it later. The question was when we were discussing about the core binding and FLT3 both. So as we know that it negates the FLT3 when someone is having a core binding factor. But is it same for everyone? I don't know. As we are short of time. So whenever asked to, so I will be little fast, as we know we are running short. So when I was asked for case presentation and in the relapse refractory setting as a single agent, so when we have a relapse refractory patient of FLT3, we are actually pushing very hard. We most of the time end up in using combination therapies actually. So most of our patients we are using with HMAs and venetoclax along with this. So I was in Kuwait when I used as a single agent, but I could not have that data here. So this patient which I came across, but I was not actively involved in the treatment. So, but we'll have a discussion because it's a very interesting. I found it very interesting. So, 47-year-old male with no comorbidities. I think this belonged to the Assam. So, where he presented with the fever, EC fatigability baseline found to have a high TLC with peripheral blasts and the flow was done, which showed the AML with monocyte differentiation. But I could not find any other genetic workup being done there. Might be some peripheral center there in Assam. So this patient was received the azacitidine with venetoclax for 7 days, azacitidine flat dose, and this patients, there's no clear cut. I could not find the reports of the disease evaluation, but this patient had an improvement in the counts and peripheral blast clearing, and patient was doing well. And but in March again, the counts started increasing to 60,000 and did a flow and found that patient is having again a AML with monocyte differentiation, and this was a failure of azavan in 6 months. So this patient then he received, again there was no genetic workup I could find with this patient. Received 3+7 induction. End of the induction 6% blast. Receive another induction with 2+5, and end of this second induction there was there's full of blast. So this patient was referred to other centers for further treatment. So when this patient was evaluated, he was next time he was evaluated in Cheney, and the bone marrow aspirate showed 66% blast, and flow confirmed the AML. There was a hypercellular marrow with grade 0 fibrosis, and this was the NGS report. So this patient, you can see that almost it's a very quite a high risk, as we were discussing, FLT3, TKD, ITD both, and the WT1. So this explains, and I think was a trisomy 8 also. So it's a very high risk patient. So next he was started with a salvage with flag plus midostril, and the course was stormy, had febrile neutropenia requiring even the inotropic supports, and this patient he underwent the marrow, but he was having a peripheral blast. The marrow was done earlier, some few blasts in the peripheral blood is showing a 18% blast. In between, receive a cycle of azacitidine because of the infections, could not proceed for further treatment. So now this patient had failed azavan 3+7, even the 2+5, the 2 inductions given, and the flag plus midostril. And we have seen his NGS a very high risk, WT1 and FLT3 ITT both. So considering that everyone was like giving up what to do now, and fortunately we had by that time available Zosparta here. So he had a fall from the bed, become tachypneic, oxygen support. Nothing was very clear. Is it because TLC was also, it was not very high, but it is because of the leukostasis or what was not very clear. But by the time the patient was started on gilteritinib, so again, he started with the start within a week time. His symptoms started getting better. He became asymptomatic. Respiratory symptoms were relieved, and this is the whole of this from CBCs that we did for this patient was done. So as you can see, this in the patient started developing cytopenias, and usually the practice might be different, but the initial phase we don't compromise the dose, as we know that patient is having disease. There would be some cytopenias with gilteritinib. So he had thrombocytopenia, he had low WBCs were low, ANC very low, and by the time patient was near completing a month time, his cytopenias started getting better. He started holding the platelets. The platelets started increasing, and by day 40, the platelets he was recovering the platelet count. So normal FLT3 plays, as we know, that role in the early hematopoiesis. So some degree of myelosuppression is expected with any FLT3 inhibitor. The advantage with gilteritinib is a much weaker inhibition of wild-type FLT3. So combined with this lack of activity against KIT, so neutrophil recovery, as we know that initially there is a drop we always see, but with neutrophil recovery occurs in 3 to 8 weeks and can even occur earlier. So in this patient, there was no requirement of dose adjustment was not required. There was no significant LFT derangement or ECG changes encountered in this patient. So that even at that time, we were not adjusting the dose with the antifungals. I'm not sure what's the practice. We'll discuss in the panel discussion. So day 25 marrow, patient had this marrow was done when there was a peripheral clearing of the blast. It's a 21% blast, but by the day 70 marrow, it was in CR with MRD negativity, and pre-transplant also this patient was CR with MRD. MRD was the flow MRD. So he underwent the haploidentical transplant. Not doing good. So this is this. Thank you. I was a little more fast because we were
Dr.
running
Paresh,
short
one
of
more
time.
thing. Does a single agent ever works in an AML?
It depends what you mean by works. So single agent can give you CR, but it doesn't give you cure.
Okay.
I mean, you have to do more things, right?
Sir, because our practice is actually when I was actually asked to present a case, I could not find a case with single agent because we most of the time we'll end up in using the combinational therapies.
No.
But this is something
So you're much more
extraordinary
likely.
response.
Yeah, you're much more likely to get a better response in combination. You're much more likely to get a slightly faster response. But in first relapse, there's very little that will cure other than an allograft.
So, Dr. Paresh, what is your choice of poison with gilteritinib? Which, in your combination, which has worked well? So, I have received 7+3 and then 3 doses of Hydac and midostaurin, and people relapse. Then, what is your choice? Does it work with Hydac, Flag, venetoclax, azacitidine? So, which combination seems to be working the best in a relapse refractory setting?
Yeah, so in a relapse refractory setting, the things to consider are firstly performance status of the patient, obviously. Secondly is what they've had before. And thirdly, the length of first CR. And in patients who've had classic 3+7, Hydac, midostaurin, and relapsed, it depends on the length of that first CR. If they've had a short first CR, I tend to go for venetoclax. I use something different. And I do that because clearly the anthracycline combined with RSC and midostaurin just didn't do it. So simply by changing the FLT3 inhibitor from midostaurin to gilteritinib, I'm not confident.
Okay.
If somebody's had a long first CR, by that I mean greater than a year, then I might be tempted to get things over quickly, give them one lot of 3+7 with gilteritinib, maybe give one lot of induction, but I'm really trying to take patients to transplant. And I'm trying to get them there sooner rather than later.
Dr. Paresh, before we go on to the panel discussion, there was just a paper published, I think in BMT in November of 2024, where they did talk that NPM1 tends to get cleared with melphalan better because we have a different combination with Flumel, Flubu, Flutrio. So have you in your experience seen which, or from the world literature, because you in Oxford must be using one particular set of things. We are in India trying to analyze this various combination conditioning regime based on the mutation status, that which is able to clear them more. We don't have a lab assay, provided you could have actually, your lab could have done that to check the pharmacogenomics of these blasts or the mutation based on and then the chemotherapeutic agents. But what is your thought about this?
Yeah, so thank you. My own view is that we standardly use Flu-Bu for a RIC regimen. For a myeloablative regimen, we would still go for Bu-Cy. We use Flumel for older patients. on occasion. And what we find is much more important is, do they come into transplant MRD positive or MRD negative? And secondly, if they're coming in MRD positive, rather than worrying so much about conditioning, we think about how the conditioning will affect the toxicity, and we also think about how much T-cell depletion we give, and what we think about is post-transplant immunosuppression. So we're much more worried about, do we give them Campath? Do we give them ATG? What dose? Do we give them 30, 60, very rarely 90 of Campath? How much ATG are we giving them? Or are we giving them post-transplant cyclophosphamide? In the haplo, that's standard, and in the MUDs, it's becoming more frequent. We still don't do it routinely in the siblings, but we're thinking about it. And then in terms of post-transplant immunosuppression, if somebody's coming in with MRD, we're much more likely to tail early rather than late, as long as there's patient can tolerate it. So that's where we're much more careful, I guess, or nuanced.
Perfect. So let's go on to the panel discussion. We have Dr. Paresh, who has been enlightening us. Dr. Nitin Sood, who's been my colleague in one of the biggest hospitals in India, run by and owned by Dr. Naresh Trihan. Nitin Sood has been a dear friend, has been trained in UK itself. Dr. Riaz Ahmed, a dear colleague from CMC Vellore, who has made me study so hard that I learned few of hematology with him. Chitresh Yadav, who's my colleague and who's the lead for AML to our group for Fortis, and he's leading a wonderful trials on FLT3 ATG, and that's a separate issue because we didn't want the GVHD upfront, but he is building up the data on FLT3 ATG. Dr. Sunil Chopade is there from Mumbai, who has been a dear friend. Farhan, we have just listened, and Dr. Srinidhi is doing a wonderful job establishing the molecular state-of-the-art genomic lab for the country. Not only this NGS, but of course the inflammatory marker panels, of course the T-cell exhaustion assays, and so on and so forth. So without wasting much of a time, can we share the presentation, please? Going on to the case number 1 directly. So how many patients do you come across with FLT3 amongst newly diagnosed cases in a year, Dr. Nitin Sood? What is your idea about ITD and TKD?
I don't have formal statistics, but I think we see about 30% of our AMLs would be having one of these mutations. So if you're diagnosing maybe one a week, 30% of that would be about 10 to 15 a year.
Oh, wow. So, and how
Yeah.
many tests positive for FLT3 in relapsed refractory setting? Is it a routine that people coming from outside or even people who were FLT3 previously negative at the first time who have relapsed with you, you will still check with them? What's your
Yeah.
views, Dr. Nitin?
Yeah, no, of course. As we heard previously, we would recheck for FLT3 in the relapsed refractory setting because there is obviously clonal evolution. So, yeah, I mean, it's slightly higher. Of course, ITD outnumbers the TKDs.
So, Dr. Paresh, very interesting seeing what Dr. Nitin said. Dr. Riaz, before I go to Dr. Paresh, because what we have seen over a period of time, I will just come back to that. Dr. Riaz, what do you think that in a relapse refractory setting, upfront patient was negative and then patient relapsed within your own center? Have you come across that people become FLT3 positive with the same assay?
Yeah, absolutely.
Yes, it can be positive. We have seen.
So, Dr. Paresh, what's your thought? Does the clone really changes? Because once you have a particular clone which has led to the AML, I thought that those were the ones which continues to go up and down rather than a new clone coming in and leading to the relapse. What's your thoughts?
Yeah, so my thought is very simple. Virtually every clone is there right from the very beginning. It's just that you can see some, but you can't see others.
Wow.
We're just not sensitive enough, right? And remember, when you do a bone marrow, you typically have, I don't know, 10 to the 7, 10 to the 8 cells that you're taking out, and you have 10 to the 13 in your entire bone marrow. So you're sampling something like a millionth of your bone marrow. So the absence of something at the beginning doesn't mean it's not there. It just means you can't see it.
Wow. That's a great thought, Dr. Paresh, because we were not able to find out so frequently that people who were negative on a deep assays now, or probably they were reported as 0.1%, now they have grown to the real clone. So probably that's the thing, and that's all. They are all because whichever lab you are getting reported the NGS, please ask them to report even 0.1% in a bracket, because you know that these clones can grow up to the next level. And we have seen people relapsing. NRAS at day 365 reported as 0.3%, and 2 years down the line, the same relapse happened in the CNS with this NRAS and FLT3 being negative. So I think that's very, very important point, that you have to keep on testing every time you relapse on the things. Next, please. Next slide. So, Dr. Chitresh, how many patients test positive upfront while they turn FLT3 negative post-induction? Is Dr.
Hello,
Chitresh there?
sir. Yes, sir. So, patients test positive upfront when they turn negative post-induction.
Yeah.
So this is quite seen, sir. Like if even they were negative, but they are FLT3 positive, even after post-induction, this can happen, sir, in approximately 10% patients.
And Dr. Paresh,
Which we have
what is your thoughts? Because we have seen relapses in a patient with a FLT3 and with good gilteritinib and midostaurin. The FLT3 clone didn't came, but the NRAS and WT1 clone came by and they relapse in CNS. What's your thought regarding that?
Yeah, I've seen this, and clearly, you know, the therapy is leading to selection, clonal selection, and the RAS clones are often very monocytic and often will lead to extramedullary disease, including CNS disease. Sometimes we've even seen myeloid sarcomas come through.
Okay, next slide.
Yeah.
We have to be slightly more quicker. Dr. Chitresh, in terms of your efficacy, what endpoints do you consider most meaningful to your clinical practice? The complete response, overall survival, composite CR, duration of response, time to response, or anything else?
Sir, safety and CR will be the two things which I will consider while choosing the FLT3 inhibitor.
Dr. Sunil and Dr. Farhan, what are your endpoints for this?
Yeah, I will choose complete remission as well as hematological recovery for like response assessment.
Perfect. Perfect. So I think in this, we should have a response to a complete molecular response, like the defined things in CML, like major molecular response. I think AML, we need to come on to together with complete remission, we need to also have a complete molecular responses based on the mutations which can achieve complete molecular responses like FLT3. And Dr. Paresh, what is your thoughts onto that?
Yeah, I mean, I think it depends if you're looking at an early endpoint or a late endpoint. Clearly, from an early endpoint, it's CR with some kind of hematological recovery to get the patient out of hospital, out of your day unit. CRC or, sorry, CRH or CR. CR is obviously better. But of course, what the patient really cares about is how long are they going to live? And so OS is important, at least for me.
Perfect. So coming on to the next case, case number 1, we'll have just time for case 2 actually. We're overshooting, going to shoot our time, but we are going to quickly run through. This is a run-of-the-mill acute myeloid leukemia, DNMT3, FLT3 positive, underwent a transplant. Treatment was given induction therapy with 7+3. Somehow the diagnosis, FLT3 ITD mutation, mutant to wild type. Allelic ratio 0.6. Sometimes we'll go back to Dr. Paresh why this allelic ratio was ever designed, and then dropped in, which created a lot of confusion in the minds of people across the world. And patient underwent a consolidation with high-dose cytarabine day 135 combined with midostaurin from 8 to 21. So one by one, Dr. Nitin Sood, what would be the test would you prefer to do before deciding on the subsequent therapy? And would you go for a FLT testing again?
So sorry, you went very quickly. So you're saying this patient is in remission now after
So no,
consolidation?
patient underwent consolidation, then relapsed, detected with peripheral blood leukocytosis of 48%, and relapsed molecular testing confirmed recurrence with NPM1, DNMT3, FLT3 mutation.
Right. So he's relapsed with his FLT3 ITD.
Yeah.
Yeah, I think as we said, I mean, because it's an early relapse, we would like to use different agents. So I mean, at the moment, gilteritinib single agent is a possibility if his performance status is not great. But otherwise, I think aza-ven gilteritinib combination also is a strong contender here.
So, Dr. Nitin, you say aza, ven, and gilteritinib. Dr. Paresh, is there any combination regarding aza and gilteritinib alone? Before I bring in Dr. Riaz, because somehow we have already been given aza, ven, and gilteritinib. In a Wiles A study, aza, ven itself produced 70% responses in a FLT3 positive. So, what is the over and above which we are going to get with gilteritinib? Because the toxicity with a triple drug is huge. So before Dr. Paresh responds, Dr. Riaz, have you ever given, or Dr. Chitresh, have you ever given only aza and gilteritinib and not venetoclax?
It has never happened. As a when, most likely, but as a gilteritinib, we have not given.
Okay, Dr. Chitresh.
Sir, as a when gilteritinib we have tried in few patients. Toxicity like marrow suppression, neutropenia was prolonged, but only as a with gilteritinib not used by me up till now. But instead of that, why not to continue gilteritinib as single therapy was my thought. That's why I have not used.
So I will come back to Dr. Paresh between the single therapy and a triple therapy. In a meantime, Dr. Sunil, what is your thoughts?
We have used in few patients azavein and gilteritinib, but as everyone is saying, I also don't have experience of using aza in combination with gilteritinib.
And Farhan, what is your thoughts?
So actually, I use a lot of this medicine. I was in Kuwait where the gilteritinib was available, and a lot many patients were on azavan and gilteritinib. The good thing with this triple therapy was that there are some number of we have to reduce the number of days for venetoclax and even the gilteritinib, and the tolerability is there. But if you ask me which is more toxic, I think ven would be the more toxic in all the three. So I think Asa and gilteritinib would be well better tolerated, but I don't know how would be the outcomes.
So Dr. Paresh, what is your thoughts? Or anywhere in the world people have tried with aza and gilteritinib? And if not, why not?
Yeah, sure. So the biggest data set for azacitidine is in the LACE-WING trial, which compared azacitidine versus aza in unfit FLT3 mutant AML ineligible for intensive chemotherapy. It was published in Blood in 2022. The CR rates were higher with azagilt, but there was no OS survival advantage. Now, it's a complicated trial because there was some crossover. In my clinical practice, I have not used azacitidine. We have used aza then gilteritinib as part of clinical trial, and here we're very, very, very careful of dose. So we do not give more than 7 days of ven. We sometimes reduce after cycle 2 because the response is fast. It's usually within the first cycle, occasionally cycle 2. We then usually reduce ven to 5 days or stop. We're using aza-ven gilteritinib really like induction. And once we get a decent response, we may drop the ven altogether. We may continue with gilteritinib monotherapy, or we will reduce both aza and ven. So 5 days of aza to get them out of hospital so they don't have to come every day. and the ven will be 5 days. So 5 days ASA, 5 days ven, 80 milligrams of gilteritinib. We never give more than 80 milligrams of gilteritinib in the triplet.
That's very helpful. So, dear all, we have to remember, we can skip 2 slides and just go to the next. So, very important next. So, very important point, what Dr. Paresh has said is that we can drop when after first cycle if there's a good response. Did I hear correctly? And did I quote it?
Yeah, you can. I mean, monitor obviously, right? So you'll see CR or you'll see CRH. The MRD will show you a good drop in disease. And then, especially if recovery was long, then drop the ven and go to monotherapy. I'm using it as induction. Now, if I'm not getting as deep a reduction in the MRD as I want, I might, for the second cycle, give 5 days ASA, 5 days ven, gilteritinib 80. And sometimes I'll give gilteritinib for 21 rather than 28 days.
Wow. That's very, very helpful, Dr. Paresh. That's a very, very valid clinical point.
Dr. Paresh, sorry to interrupt. So for MRD, making MRD negative in relapsed refractory patient who are also FLT3 positive, you are using ASA when gilteritinib.
Yeah, exactly. And then if they're young enough and we didn't use intensive, so and as I said earlier, imagine they relapse within a year of having an intensive-based regimen. We'll use ven-aza gilteritinib 1, 2, 3 cycles transplant.
Because it is very helpful, Dr. Paresh, because it's going to reduce the cost of treatment for 2 cycles before the transplant. And that's the one thing, a drug which is wonderful in inducing the deeper remissions. So what I heard in past 1 hour is, if I have to really summarize it, that gilteritinib is a faster acting drug which leads to deeper MRD, which means instead of giving 6 months of midostaurin, you give in a relapsed refractory setting ASA ven gilteritinib at a lesser dose so that you save the cost and go on to the transplant as early as possible without inducing too much of toxicity, which becomes counterproductive for TRM later down the line. Is that the right statement?
Correct.
Perfect. And you save money because every indoor hospital patient costs money. At Fortis, we don't give ASA ven in indoor patients. We give it as an outdoor patient. So we also have to build in the cost for the admissions as well as blood and platelets. So coming back to the panelists, rapid fire round. Dr. Nitin, PCR or NGS testing for FLT3? Is it in-house or external lab? What is the turnaround time and what do you do?
Ideally NGS, but our NGS is not validated for, and that'll happen with most of the people. The NGS is
Just go to the
in-house.
previous slide.
We have in-house NGS. The problem is the turnaround time is a week to 10 days, depending on the batch size. And then it's not really validated for MRD testing. So we end up doing a flow MRD.
And do you do PCR for diagnosis for FLT3 or still relying on the NGS?
No, we do both. We do PCR and NGS.
Riaz, what is your thoughts?
Yeah, same Rahul. PCR generally is sent, but NGS is much better again. PCR is little early, so if it is a upfront case, deciding on FLT3 inhibitor, PCR helps. But NGS will like to have, as for the MRD, we cannot have, again, it's not validated. Same here. The in-house is there, but it's not validated for the MRD. So,
and Dr. Sunil, what is your thoughts onto this? Probably Dr. Sunil has gone. Dr. Chitresh?
Yes, sir. So as I work with you, so currently we are using NGS upfront both for MRD testing and upfront also and MRD testing also. And turnaround time is 3 days.
Yes, so actually we can actually collaborate in this study because we have found a mutant which is was resistant to gilteritinib, and so we have to revert back to midostaurin. So some one odd cases you can find where the resistance can be found in the FLT3. Dr. Paresh, have you found in your larger databases where people are resistant to gilteritinib?
Yeah, there are patients resistant to gilteritinib, absolutely. We've never run, I mean, most of the time it's because of other co-mutations. You've talked about RAS, very obvious, and terrible. P53, terrible. So it's clonal evolution. Patients can retain that FLT3 mutation within that clone. Occasionally patients will chop and change their ITDs. In general, and I think this was shown initially by the first speaker, that you actually have many, many ITDs. Sometimes you can have quite a few ITDs. It just shows the selection is so strong for the gene mutation, and the ITDs will swap. And sometimes I wonder if all ITDs are created equal. I don't think they are, and there was a discussion in the first talk about that. The data for that is a little bit confusing. Different people are saying different things, but I don't think all ITDs are created equal. And here, I think the more potent your inhibitor, the better.
So before we wind up and ask our panelists to raise the questions, my only question to you is, if those people have used midostaurin previously or sorafenib previously, do you think that gilteritinib can still be used, or there's a mutation which happens where it will preclude not getting used by with a prior use of midostaurin?
Yeah, so the answer is in two parts. Yes, I always use gilteritinib. And yes, there are some patients who have prior TKI who will not respond to gilteritinib. But I don't think there's a clear-cut mutation that you say you must not use this with gilteritinib. We don't yet know exactly what mutation will not work.
Perfect. So I think there are many slides where we have already discussed with things. So Dr. Nitin, do you have any burning questions? Dr. Chitresh, Dr. Riaz, Dr. Farhan, or Dr. Srinidhi to Dr. Paresh before we wind up? You can directly ask him.
I do have one question, sir. In post-transplant cases, when to start gilteritinib, how much dose you give, and especially in case where there are poor graft function or PRC, how do you titrate the dose?
Yeah, great question. So typically platelets over 50, neutrophils over 1, no more than 80. And sometimes we might even do something like 80 once every other day. And, cytopenia is a big issue. So we think of everything else that they're on that we could stop that may be suppressing their counts. And, the most important thing is to keep AML away.
What was the last bit? What was the last bit?
Really important to keep AML away.
Okay. Another question. Dr. Chitresh, one question to Dr. Paresh, because last week when we were having a Sunday meeting with Dr. Jayastu from MD Anderson, he was saying that irrespective of FLT3 wild type status or mutant status, they have started using quizartinib in else. What is your thought onto that?
Yeah, so I think I mentioned that Pao Montesinos has this data for quizartinib in FLT3 wild type. Not everybody in the world believes it, but I think it's a reasonable thing to do. There is a study called Quantum Wild that Daiichi Sankyo is running to compare quizartinib in patients of FLT3 wild type. My current clinical practice, I don't do it. I would like to see more data from more than one center.
So, Dr. Nitin, you have any question?
One question I want to ask for everyone. So what is the usual practice when we with gilteritinib with antifungals like posaconazole? So do anyone reduce the dose, or uniformly everyone gives 120 also?
So, Dr. Paresh, what is your thoughts?
We reduce dose, we give 80. And we
Perfect.
try and use isavuconazole when we can. We normally use posaconazole, but in those instances where we, particularly, for example, if there's we're worried about counts, we'll go to ISO and we'll give 80.
Perfect.
We're not worried about counts, we just go to 80.
So another question with the core binding factor leukemias with FLT3, as we know that core binding negates effect of FLT3, and what is your take? Does it actually, because as per the guidelines we see this, but what you see in your real time practice?
So we don't see much FLT3 in core binding factor, I have to say, here in the UK. And we use Mylotug all the time. So that's a big difference.
Yeah, I think the Indian physician has to get up together to ask the Pfizer to bring Geo, because that's a recurrent thought that CBF being overcome by the Geo, and that's why probably we are not doing so well. So another question is, in APML, have you ever seen in a relapse refractory setting where the FLT3 is positive, people using gilteritinib or any other inhibitors?
Sorry, can you repeat
We
the
do
question?
see
In
a lot of
APML,
FLT3 in APML.
relapse refractory setting.
I think 30-40%.
In a relapse refractory APML setting, have you ever tried using gilteritinib?
No, we don't typically use it. So the data now with arsenic and ATRA is so good.
Yeah.
We rarely lose patients. We lose patients in the first week from DIC.
Yeah.
We-
Yeah.
But we
That's-
rarely, I mean, I can't remember the last time we lost a patient.
Yeah. So with this, we come to an end. Dr. Nitin, you have any questions? Any of my fellow
Yeah.
panelists has got a
Can I
question?
just quickly ask one last question? I mean, based
Please.
on the Admiral data, are you confident using gilteritinib as a single agent?
Great question. Great question. So my preference, when I can, is to use it in combination. If I can't, I will use it as monotherapy.
Perfect. So I think it's a great evening we had, Dr. Paresh. We have learned so many new things and looking for collaborations with your esteemed lab with Dr. Srinidhi and my colleagues. It's a wonderful opportunity. We are in Gurgaon. Till the time you can't send the sample to Dr. Paresh in Oxford, you can try us in Gurgaon. With this,
So
thank you.
I hope to meet you. I come to India once a year. My mother lives there.
Where?
Ahmedabad.
Oh, very nice. So looking forward to see you and host you in Delhi sometime, Paresh.
Fantastic. I'll let you know when
Perfect.
I'm coming.
Perfect. Thank you, Paresh. Thank you for this wonderful evening. Thank you. Bye-bye.
Thanks. Bye.
Thank you very much, Dr. Paresh Vyas and all the other faculty. Thank you.